He's going to talk about the most relevant topic for day-to-day practice, RSSDI Clinical Practice Recommendations.
Thank you, sir. Good morning, everyone. At the outset, I would like to thank Dr. Vijayakumar and Team D3 for this very kind invitation. And as you are aware, I'm going to speak very briefly about the clinical practice recommendations from RSSDI, which we released at the RSSDI National Conference held in Chennai in October. And I'm sure most of you were there when the guidelines were released. Now, important thing is that we have been publishing these clinical practice recommendations for almost 8 years now, and they are being revised every 2 years. But still there are issues relating to the interpretation of these recommendations and the application of these recommendations to clinical practice. So, what I'm going to do in this presentation over next about 20 minutes is give you a very brief outline of what all this recommendation document contains, and then touch upon how it helps in taking decisions in clinical practice relating to management of diabetes. So this is the guideline review committee that you see here, and this was a very extensive exercise conducted over 3 months period. We had more than 140 experts involved in development of this clinical practice recommendations, and this has 26 sections. Now, previous version of the clinical practice recommendations had 22 sections, of which one was deleted and 5 new sections have been added. And there are changes in titles of some of the sections, and there is inclusion and modification of some data in most of the sections. All the sections have been updated with the recent studies and references. And I'm going to take you through the titles of these references, and against every section you see the people who were involved in development of these sections. So wherever you see a blue highlighting, this means there were significant changes made in these sections, and wherever you see a orange highlight, that means a new section that has been added. So earlier section on diagnosis was improvised to increase the context, and this was changed to diagnosis and classification of diabetes. The next section on prevention was expanded to include the remission of diabetes, because this has become an important area of concern. Then we had a section of individualizing therapy now, which was expanded to include individualizing therapy and precision medicine as far as the management of diabetes is concerned. All other sections also have been updated, and new references and new data has been included there. The chronic complications section was expanded to include stroke and diabetic foot. The diabetes and heart section was expanded to include the heart failure, which is again very important area to be considered in people with diabetes now. The vaccinations section was expanded to include the latest recommendations. The section on glucose monitoring was expanded to include clinical monitoring. That means it included monitoring about lipids, obesity, everything that matters in diabetes. And there were new sections on type 2 diabetes in young and adolescents, hyperglycemia in pregnancy, type 2 diabetes in hypertension, and diabetes in elderly. And one of the sections that was deleted was the complementary and alternate therapies, because we thought that we are doing evidence-based medicine. This is an area where we don't have expertise, so best we don't deal with this section. Now, the whole document is divided into 2 levels of care, 2 standards of care. One is the recommended care and other is the minimal care. And this is done because we think that we have resource constraints in most of the parts of country, and we have to have a minimal level of care also recommended. Second thing is, when the guideline, this consensus document was developed, this was a derived guideline based on the IDF clinical practice recommendations. And IDF recommends 3 levels of care: comprehensive care, standard care, and minimal care. So we removed the comprehensive care to have only one level, standard care and minimal care. So recommended care or standard care is the evidence-based care that is cost effective, and that should be the intervention which should be made available to all people living with diabetes, and that should also be the goal of all healthcare system, to provide that level of care for management of diabetes. The minimal level of care is the lowest level of care that seeks to achieve the most or major objectives of diabetes management, despite whatever there are constraints in terms of manpower, resources, availability of tools, monitoring, whatever. This is the minimal level of care that should be made available to all people living with diabetes. Now, there is major section is how to individualize therapies and use the concept of precision medicine. So for all people with type 2 diabetes, the first line therapy should be lifestyle interventions and metformin, and a patient-centric approach defined as A, B, C, D, E, F, G, H approach has been, this was included, I think, in 2018 and has been carried forward, but some changes had been made in the current modification also. Choice of anti-diabetic agent should take into account the patient's general health status and associated medical disorders. Now, what is A, B, C, D, E, F, G, H approach? So, this is the consideration, 8 major considerations or factors which determine the management or clinical treatment strategy for people with diabetes. And these 8 factors include age, body mass index, presence or absence of CKD or the renal function compromise, duration of diabetes, established cardiovascular disease. Financial concerns is one of the areas which is not included in any clinical practice recommendations anywhere in the world. But it is a very important consideration in India because it is out of pocket payment for everybody, more or less, and that is why this concern is always there. Then is the glycemic status and the hypoglycemia concern. So for people diagnosed with diabetes, you have to consider a combination of metformin and one more treatment option based on the ABCDFG approach. And how we apply this approach, I will show you in next slides. The drug choice should be based on patient preference, the presence or absence of various comorbidities and complications, the drug characteristics, the A1C lowering capacity, and so on. So you have to have a patient-centric approach finally when you are choosing a therapy. Also keep in mind that comparative effectiveness meta-analysis of various anti-diabetic therapies have shown that all of them lower A1C by 0.9 to 1.1%. So average A1C lowering is only 1% irrespective of whatever agent you are using, except for GLP-1 receptor agonist and insulin, which can give you a higher A1C reduction. And this approach is put up very nicely into this wheel, what we call as therapeutic wheel, and you will see various sections here. So each section denotes one of the consideration. A is for age, B is for body mass index, C is for the renal function, D is for duration of diabetes, established cardiovascular disease, financial concerns, the glycemic status, and the hypoglycemia concern. And when you have to interpret this wheel, you have to keep in mind that as you move away from the center, each consideration increases in intensity or the level of concern. So when you are in the center, basically you have a garden variety of type 2 diabetes who is just newly diagnosed, does not have any risk factors and no major concerns as far as the comorbidities are concerned. So suppose you have a person who has, who is newly detected diabetes and is in green zone. That means there is hardly any concern of kidney function or body mass index or age or hypoglycemia concern. So in this green zone, you can choose any of the agents, right? You have no major consideration. You can choose any of the agents that you prefer for the patient, and the patient is okay using that agent. But as you move away from the center, you enter the yellow zone. That means each consideration is now moderately important. And once you reach the red zone, that means that consideration is of great importance when you are considering or finalizing the therapy. So suppose you have a person who has a duration of diabetes, say 20 years. So he is already in this zone. That means he has burnt out diabetes, unlikely to respond to the agents like SGLT2 or DPP-4 inhibitors or pioglitazone, and you may need insulin as the first option. You have body mass index, which is morbid obesity. The preferred drug would be SGLT2 inhibitor or GLP-1. You have advanced age, where age is the major concern. You don't want them to have a fall or difficulty of using insulin. The hyperglycemia is not a major concern. Major concern is hypoglycemia. So preferred drug would be a DPP-4 inhibitor or AGI maybe in this group. And how we apply this, I will show you in some of the case studies here. So this is a typical patient presenting in the clinic, 48 years old male, businessman, diabetes for 3 years, A1C has increased to 8.4% in last year. He has attempted lifestyle changes but of no use. He's already on Ramipril for hypertension, does not want to take any injectables. BMI is 32.5. Blood pressure is more or less close to target. He has, indicators of insulin resistance. A1C 8.4%, fasting postprandial in the range of 187 to 94, creatinine normal, EGFR is normal, lipids, triglycerides high, rest everything is fine. And he's already on metformin. So what OAD would you like to add? Because he doesn't want injectables. So now if we try to analyze the important factors in this person, he is 48 years, so age is not a concern. He is only 3 years duration of diabetes, does not want injectables. The major concern is his BMI. Nothing else is a major concern here. Now, if we go back to the wheel, and if we look at the BMI as concern, the preferred drugs would be SGLT2 inhibitors or GLP-1 as addition to this metformin. Now, he doesn't want to take injectables, so first option becomes here SGLT2 inhibitors, and that this is how you decide that this patient should be added SGLT2 inhibitors, and if that doesn't also work, you have to counsel him again, maybe give him GLP-1 receptor agonist. Now there is another patient who is 70 years old, smoker, has documented atherosclerosis, diabetes is there for 12 years, hypoglycemia happened earlier, but he is aware about hypoglycemia, A1C is 8.6%, has history of myocardial infarction, compensated heart failure, stage 2 CKD, microalbuminuria, multiple risk factors, and already on metformin. Now what agent we should think of? So again, look at the major consideration. Age is one of the consideration. Presence of established atherosclerotic cardiovascular disease is another consideration. Presence of CKD is another consideration, and multiple risk factors. So multiple considerations you have to keep in mind. Now let us look at the wheel. So let us look at age as a consideration. So ideally he should be on, if age becomes a major consideration, he can be a candidate for DPP-4 or AGIs or maybe SGLT2. But here bigger consideration is established cardiovascular disease. First option would be SGLT2 inhibitor or GLP-1 receptor agonist. So in established atherosclerotic cardiovascular disease and CKD, we have kept the hierarchy of SGLT1 here, SGLT2 inhibitors here, because one, they are oral agents, and second is the cost. That is why we have not used GLP-1 as first in preference in any of the categories in Indian setting. Now keeping this in mind, first option becomes SGLT2 inhibitor. Now CKD is another concern. Again, it becomes SGLT2 inhibitor. Hypoglycemia is another concern. Again, it becomes SGLT2 inhibitor. So if you put all these considerations together, the first option would be addition of SGLT2 inhibitors or GLP-1RA. Now you have another patient who is again same age, non-smoker, but no atherosclerotic cardiovascular disease, recently diagnosed diabetes, A1C also in the same range. But now this guy is frail. He has osteoarthritis. He is not able to walk properly. He is frail. He has, risk of fall. And he has risk factors but no established cardiovascular disease, again on metformin. So what would you like to add? Now considerations are totally different. You don't have atherosclerotic cardiovascular disease, you have only risk factors, no CKD. Age and frailty are two concerns. Otherwise, there is no major concern. So we don't want him to have hypoglycemia. We want to prevent falls. And there, if you look at the aging as the major consideration, the first preference would be a DPP-4 inhibitor here. So if you want to, if you analyze every patient based on this wheel, you are generally, able to achieve arrive at a good decision as far as the management of diabetes is concerned. So with that, I come to, my concluding slide. Just to reiterate that RSSDI clinical practice recommendations for management of type 2 diabetes are very, very practical and simple to use. They provide you practical approach in all clinical scenarios, and they are very relevant to Indian setting because we are taking care of the cost, the availability of medication and other factors. Thank you. Thank you so much.